We've all been there. You have the sugar talk for the 100th time, you nail the flossing demo, and the patient is nodding along, swearing they get it. So why are you staring at a new lesion on someone who insists they're doing everything right? It's that frustrating moment that makes you second-guess your own diagnosis. But what if the problem isn't their compliance? What if it's a hidden factor you were never taught to look for? Today, we're exposing 7 of those sneaky culprits behind your most baffling cases. You've mastered the patient ed basics. You preach diet, hygiene, and bacteria until you're blue in the face. Yet you're still seeing new caries pop up in your most diligent patients, undermining your hard work and frustrating you both. The classic textbook triad, bacteria, diet, and a susceptible host, is a great foundation, but it's incomplete. It doesn't account for the complex real-world factors that can tank a patient's risk profile, sometimes overnight. So today, we're moving beyond the textbook. This is your clinical guide to the lesser-known culprits sabotaging your treatment plans. By the end of this video, you'll have a new diagnostic checklist to stop these saboteurs in their tracks. The prescription pad problem. Often, the most common cause of rampant caries isn't hiding in a secret candy stash. It's right there on the patient's medication list. Medication-induced xerostomia is one of the most powerful risk factors we see, with hundreds of common drugs known to cause dry mouth, from antidepressants and antihistamines to blood pressure medication. Here's the classic presentation: a middle-aged patient, a regular 6-month recall, with a perfect diet and stellar home care. For years, nothing but clean checkups. But today, you spot new, sticky cervical caries on their premolars and anteriors. It makes no sense. But a quick look at their medical history reveals the missing piece. 6 months ago, their doctor put them on a tricyclic antidepressant. The mechanism is often an anticholinergic effect, blocking the signals that tell the salivary glands to get to work. When you lose that salivary flow, especially when it drops below the red flag rate of 0.1 milliliters per minute unstimulated, the mouth's natural ability to buffer acid and clear debris is gone. It's the perfect storm for decay. The takeaway? Always cross-reference new, unexplained caries with changes in medication. For these patients, high fluoride toothpaste and xylitol mints aren't just suggestions, they're essential. And if you can, advise them to take xerogenic meds in the morning. Nighttime dry mouth is a whole different level of risk. The silent destroyer, bruxism. Next up is a mechanical problem with a serious chemical consequence: bruxism. We tend to think of grinding in terms of TMD or fractured cusps, but its role in causing cavities is massively underestimated. Picture this: a young professional in their 30s, stressed at work, complaining of morning headaches. You see the telltale signs: flattened molars and some incisal chipping. Their bite winds show what looks like early occlusal decay, but visually the surfaces just look a bit stained and rough. The immense force from bruxism, sometimes over 250 pounds per square inch, creates microscopic cracks and roughens the enamel. These worn-down areas become perfect little plaque traps, impossible for a patient to clean. As the enamel thins, the much softer dentin gets exposed, dramatically speeding up decay. It's a 1-2 punch: mechanical wear followed by chemical breakdown. Your game plan has to be twofold. First, stop the parafunction with a custom occlusal splint. It's non-negotiable. Second, get aggressive with your prevention. That means fluoride varnish on every worn surface at every recall appointment. When you see wear facets, don't just think about fractures. Think about the hidden risk for decay and act accordingly. The aging restoration. The third hidden pathway is the eventual breakdown of our own work. No matter how well placed, dental restorations have a lifespan. They weaken, their edges get rough, and they create tiny gaps where plaque loves to hide. It's no surprise that secondary caries is still a leading cause of restoration failure. You've seen this a million times. A patient comes in with a big 15-year-old amalgam or composite. It looks fine at first glance, but the bite wing tells the real story: a dark shadow creeping right under the margin. That's microleakage. Whether it's from material fatigue, shrinkage, or just years of chewing, a microscopic gap forms at that tooth restoration interface. This gap is a superhighway for bacteria and acid to sneak in and start a cavity where no toothbrush or floss can ever reach. We have to be detectives here. Trust your radiographs, but also trust your explorer. That tiny catch at a margin isn't just something to watch, it's a warning sign of failure. While polishing a rough spot might buy you a little time, if that marginal seal is broken, the only real fix is to replace it.
The iceberg effect, hidden caries. Number 4 is the classic hidden cavity, what we call occult caries. These are the lesions that are invisible on the outside, but are secretly raging in the dentin below, detectable only on a radiograph. They are precisely why we take bite wings on patients who look cavity-free. Imagine a teenager with newly erupted second molars. The occlusal surfaces look perfect, no stain, no stick, but the bite wing reveals a huge radiolucency deep in the dentin. What happened? The deep, complex pits and fissures of some molars create the ideal hideout for bacteria to thrive, completely shielded from a toothbrush. Acid production eats away at the tooth from the inside out, while the surface enamel stays intact, just like the tip of an iceberg. This proves a critical point. You can't trust your eyes alone, especially on high-risk surfaces. The best defense is a good offense. Sealants on newly erupted molars and premolars are the single most effective way to block off these anatomical traps. And for diagnosis, tools like laser fluorescence can be a huge help, detecting bacterial activity in a fissure long before you'd ever see it on an X-ray. The systemic shift, hormones. Our fifth culprit isn't in the mouth at all, it's in the patient's endocrine system. Major hormonal shifts during puberty, pregnancy, and menopause can send a patient's caries risk through the roof, even if their diet and hygiene haven't changed one bit. Take the classic example of a pregnant patient. A 30-year-old in her second trimester who has always had perfect checkups suddenly shows up with inflamed gums and a few new cavities. Research confirms that elevated pregnancy hormones like progesterone and estradiol can alter the oral microbiome, leading to higher levels of Streptococcus mutans. These shifts can increase inflammation and reduce saliva's protective qualities, significantly elevating caries risk. The same logic applies to teens going through puberty and postmenopausal women. The clinical lesson here is to be on high alert during these hormonally active times. For pregnant patients, more frequent cleanings and fluoride treatments should be standard procedure. It's all about recognizing that the body's natural defenses are temporarily down and stepping in with extra support. The foundation flaw, poor nutrition. Just like a house with a weak foundation, teeth built without the right nutrients are far more susceptible to decay. Our sixth hidden cause goes back to the building blocks of the tooth itself, nutritional deficiencies. Think about a patient with a history of restrictive dieting or a malabsorption issue. Their enamel might look a bit dull or chalky, and they get cavities despite being great with their hygiene. It's not so surprising when you look at what enamel is made of. A vitamin A deficiency can lead to flawed enamel formation. Vitamin D is absolutely critical for absorbing the calcium and phosphate that make up the enamel matrix. Studies have shown that children with adequate vitamin D levels have fewer cavities, and vitamin C is vital for healthy dentin. As clinicians, a quick dietary history is an underrated diagnostic tool. When you see weak enamel or a caries rate that just doesn't add up, ask about their overall nutrition. Are they getting enough calcium and fat-soluble vitamins? We're not nutritionists, but we can spot red flags and refer them to a physician or dietitian. For these patients, topical fluoride is just a shield. Fixing the underlying nutritional issue helps strengthen the tooth from the inside out. The interproximal blind spot. Our final hidden pathway is the one we all know but still fight with every day, the space between the teeth. Interproximal decay is so insidious because it's a blind spot, both for the patient's brush and our own eyes. The story is familiar. A patient brushes like a champ but admits to flossing only when I think about it. Visually, everything looks great, but the bite wings show those telltale triangles of decay starting on the proximal surfaces of the premolars. That contact area creates a perfect, undisturbed hideout for biofilm. Without the mechanical cleaning from floss or an interdental brush, acid just sits there and slowly eats away at the enamel. By the time you can see it clinically, significant damage has already been done underneath. The challenge is detection and motivation. For detection, bite wings are still the gold standard, though newer tech like near-infrared transillumination, NILT, is helping us spot these lesions even earlier than X-rays. But the real solution is behavioral. We have to go beyond just asking, do you floss? Show them how to make that C shape. And for patients who hate flossing, find an alternative they will actually use, like a water flosser or interdental brushes. The best tool is the one they use consistently. So, to keep your treatment plans from getting derailed, it's time to start thinking like a clinical detective. Look past the brush and the diet. Cross-reference new decay with the med list to check for dry mouth. See wear facets and think caries risk, not just fractures. Question the integrity of your own work because a failing margin is an open invitation for bacteria. Trust your x-rays to see what your eyes can't. Amp up your prevention during times of hormonal flux. Ask about nutrition when the enamel just doesn't look right. And finally, double down on helping patients conquer that interproximal blind spot. Adding these 7 factors to your mental checklist will help you solve those frustrating cases that once left you stumped. If this kind of dental detective work gets you excited and you're ready to solve even more complex cases, check out our full online course on advanced treatment planning. The link is right there in the description. It's packed with practical, chair-side strategies designed to help you elevate your practice.